Hey everyone, if you're a pathology trainee, you know that your report is, well, everything. So today we're diving into the Pathologist's Playbook, really breaking down the College of American Pathologists, or CAP, template for breast cancer biomarkers. The goal here is pretty simple. By the end of this, you'll feel way more confident every time you sit down to write one of these reports.
But first, let's just take a second to really let the weight of what you do sink in. That report you're writing, it's not just a piece of paper with some findings. Nope, it is the roadmap. It's the guide that oncologists use to make absolutely life-altering decisions. Every single percentage, every score, every little comment you write, it all directly shapes a patient's treatment and their future. It really does all start with you.
All right, so here's our game plan. First, we'll talk about why standardized reporting isn't just bureaucratic nonsense. It's essential. Then we'll get into the real nitty-gritty, reporting hormone receptors and decoding the beast that is HER2. We'll also touch on KISS-67, and we'll wrap it all up with what is arguably the most important piece of the puzzle, quality control.
So, why do we hammer on standardization so much? Look, it's not about just ticking boxes on a form. It's about creating a universal language. When your report is clear and consistent, an oncologist anywhere in the country can look at it and know exactly what's going on. They can make the right call for their patient fast. This is all about patient safety, pure and simple.
And this is where that template becomes your best friend. Think of it as a built-in safety net. It knows the expected patterns. For instance, a low-grade tumor, it should almost always be ER positive and HER2 negative. So if you see a result that bucks that trend, like it comes back ER negative, the template basically waves a big red flag at you. It makes you stop, think, and double-check, which can prevent a really critical error.
Okay, let's get into the actual biomarkers, starting with the two big ones, estrogen and progesterone receptors, or ER and PGR. Nailing this part of the report is a huge part of your job because it's what tells the oncologist whether the patient can even get endocrine therapy. Now, within ER reporting, there's this really important gray area you have to get comfortable with. It's called ER low positive. This is for tumors where only about 1 to 10% of the cells are staining positive. And listen, this isn't just weakly positive. It's a whole separate category for a reason. These tumors are biologically tricky. The patient might get endocrine therapy, but the cancer itself often acts more like an aggressive ER-negative cancer.
This table really lays it out. More than 10%? That's positive. Less than 1%? That's negative. But see that slice in the middle, that 1 to 10% zone? You can't just report the number. You have to explicitly label it low positive. And you have to add a very specific, required comment to give the oncologist the full story.
And this is that comment. You don't have to make it up. The CAP template gives you this exact wording. You have to include it, word for word, for any ER low positive case. It communicates that tricky nuance perfectly. It says, yes, this patient can get treatment, but hey, be careful because biologically, this cancer might not play by the rules. Getting this right is so important.
So how do you actually decide if something is 10% or 80%? I mean, visual estimation is a skill, and let's be honest, it's not always easy. That's exactly why CAFAPE gives you this guide. It's a tool to help you train your eye, to calibrate what 20% or 50% really looks like. It might seem simple, but using this makes your reports so much more accurate and reliable. All right, we've navigated the nuances of ER. Now, let's move on to the complexities of HER2. This biomarker can be a real headache, you know? It often takes a two-step process to get a final answer. But it's absolutely worth the effort because it opens the door to some incredibly powerful targeted therapies. And it all starts with a screening test called IHC. So the first step, the IHC scoring, is pretty straightforward. A score of 0 or 1 plus means it's negative. A score of 3 plus means it's positive. Simple enough. But the magic number here is 2 plus. A score of 2 plus is considered equivocal. That's your trigger. When you see a 2 plus, you don't make the final call. That's your cue to send it for a more advanced test, in situ hybridization, or ISH. Okay, so you've ordered the ISH test. The results are going to sort the tumor into one of these 5 groups. As you can see, it's not just a simple yes or no. It's a detailed breakdown based on 2 key numbers, the HER2/CEP17 ratio and the average number of HER2 signals in each cell. This is where the real molecular detective work begins.
Now this is the key. For those middle-of-the-road ISH groups, groups 2, 3, and 4, you can't just look at the ISH result alone. You have to bring your original IHC score back into the picture. Check out group 2.
If the ISH says group 2, but your IHC was a 3+, the final answer is positive. But if that same group 2 ISH result came from a case where the IHC was 0, 1, or 2+, the final answer is negative. It's an algorithm, and following it is how you ensure you're getting the right answer.
So why do we go through all this trouble? Because the game is changing. What we consider an actionable HR2 result is evolving. We now have these new categories, HR2 low and even HR2 ultra low. In the past, these would have all just been called HR2 negative, end of story. But today, patients with metastatic disease who fall into these categories might actually be eligible for brand new, super effective drugs. Your precise reporting is literally opening doors to new treatments.
Okay, so ER and HER2 are the heavyweights that directly guide therapy, but there's another marker you'll see on the template all the time, Ki-67. It's not always required, but it gives us another really important piece of the puzzle.
So what is Ki-67? It's basically a marker of how fast the tumor cells are dividing. It tells you what percentage of cells are actively trying to make more cancer cells. Now, it doesn't point to a specific drug like ER or HR2 do, but a high Ki-67 is a warning sign. It tells you this is probably a more aggressive tumor, and it usually tracks with a higher histologic grade. It's just another layer of information that helps build the complete story of that cancer.
We've talked a lot about scoring and interpretation, but honestly, none of that means anything if the tissue you're looking at is bad. And that brings us to our last and maybe most critical point, quality control. Your report is only as good as the specimen. If the sample is compromised before it even gets to you, you could end up with a totally wrong answer.
This, right here, is your go-to troubleshooting list. If you get a result that feels wrong, like an ER-negative result in a tumor that should be positive, run through this in your head. Was the cold ischemic time, the time from when it came out of the patient to when it hit formalin, too long? If that clock goes past an hour, the proteins can start to degrade. Was the fixation time right? Did someone use a harsh decalcification agent? Knowing these common lab pitfalls is so important because it helps you catch a potential false negative before it ever leaves your desk. So we'll end on this question. The fact that we now have categories like ER low positive and HER2 low proves that this field never ever stands still. New therapies and new biomarkers are always just around the corner. So the real challenge for you isn't just to master the playbook we have today, but to commit to being a lifelong learner. That's how you'll make sure your reports always stay sharp, precise, and powerful tools for your patients.